Hello everyone. So today let's talk about Parkinsonism. Parkinsonism is a general term used to describe a symptom complex manifested by trap symptoms. So what are these trap symptoms? Trap symptoms includes tremors, rigidity, akinesia or bradykinesia, and postural instability. So, Parkinsonism and Parkinson's disease are two different terms, but most common cause of Parkinsonism is Parkinson's disease. But Parkinsonism includes many other causes as well. So, let's talk about the causes of Parkinsonism. The most common cause, as I already told, is idiopathic Parkinson's disease, which includes 80% of the cases. Other causes include cerebrovascular disease, drugs and toxins like antipsychotics, sodium valproate, lithium, metoclopramide. In antipsychotic, it is more common with the first generation ones, and other causes include the neurodegenerative disorders like it is also called, these neurodegenerative disorders are also called atypical Parkinsonism or Parkinson plus syndromes. It includes dementia with Lewy bodies, progressive supranuclear palsy, multiple system atrophy, Alzheimer's disease, etc. There are genetic causes as well, and these genetic causes causes Parkinsonism in younger people, younger group. So it includes Huntington's disease, Wilson's disease, spinocerebellar ataxia, etc. There are many other causes, but I have only listed the important ones and which are easy to recall. Other causes include anoxic brain injury as well. Okay, so let's talk about Parkinson's disease. Parkinson's disease is a chronic progressive disorder in which idiopathic Parkinsonism occurs without the evidence of widespread neurological involvement. So, talking about the epidemiology, its incidence increases with age, and the average age of onset is 60 years. So, it is a disorder of old age, and it is more common in males, and having a first degree relative affected increases the risk of getting Parkinson's disease. So, pathophysiology, first we need to understand that in the basal ganglia, the neurotransmitter acetylcholine, it inhibits the movement, while dopamine, it promotes the movement. So in Parkinson's disease, there is depletion of these dopaminergic neurons in the substantia nigra of the midbrain. So this lack of dopaminergic input of the striatum, which is a structure of the basal ganglia, it results in hypokinetic movement disorder. So Parkinson's disease is a type of hypokinetic movement disorder. So this is the main pathophysiological process implicated. There are other pathogenesis as well, which includes accumulation of Lewy bodies due to the mutation of the alpha-synuclein or Parkin genes. There are some environmental factors implicated as well, but there is no conclusive evidence against for this yet. So it includes rural living, drinking well water, pesticide exposure, oxidative stress due to MPTP, which is a toxin, methylphenyl tetrahydropyridine. And it is also noted that non-smokers are at higher risk than smokers to get Parkinson's disease. So there are no conclusive evidence against this for this yet. So these are the pathophysiological processes leading to Parkinson's disease. Now let's move on to the clinical features of Parkinson's disease. So there are two categories of clinical features, the motor symptoms and the non-motor symptoms, signs and symptoms. So first let's talk about the motor symptoms. Motor symptoms, they are asymmetrical in onset and gradually becomes bilateral within a year. So it includes the trap symptoms that we talked about, TRAP, tremors, which is the early symptoms. Earliest symptom of Parkinson's disease is tremor, and it is more prominent at rest and it worsens with stress. So it is called resting tremor. It causes pill rolling of the fingers and wrists, so it is also known as the pill rolling tremor, and it disappears on voluntary movement and sleep. Another symptom is rigidity. So rigidity, it refers to the increased resistance to passive movement, and it causes stiffness and a flexed posture. So there are two types of rigidity noted, lead pipe rigidity and cogwheel rigidity. Lead pipe rigidity is the rigidity throughout the range of passive movement, but there is no tremors. Cogwheel rigidity is tremor superimposed on the rigidity. So there is ratchet-like jerkiness felt while doing passive movement. Another symptom is akinesia or bradykinesia, which refers to lack or slowness of the movement. There is slowness or difficulty in initiating voluntary movement and decrease in the automatic body movements like swinging of arms while walking. And there is also mask-like face, expressionless face. And there's a sign called Meyerson's sign, which refers to when we tap on the glabellar tap, it produces a sustained blinking response. So that is called Meyerson's sign. Another feature due to bradykinesia is micrographia. So it is due to a combination of tremors, rigidity, and bradykinesia, such that the patient writes very small letters, micrographia. And there is also difficulty in tying shoelaces, buttoning and unbuttoning, and rolling over in the bed. Other features include postural instability, postural changes, like the patients have a stooped posture, and gait changes. There is a short, shuffling, or festinating gait. And there's also problems with speech and swallowing. The patients with Parkinson's disease, they have a soft, monotonous, flat voice, and they may also stutter. There's increased salivation or drooling, and there may be dysphagia as well, and these may lead to aspiration pneumonia. So these were the motor symptoms. Now let's talk about the non-motor symptoms. Non-motor symptoms include autonomic dysfunction, like including orthostatic hypotension, urinary incontinence, constipation and sexual problems, sleep disorders including restless legs, insomnia and daytime somnolence, neuropsychiatric features like anxiety, depression, psychosis and dementia, and rheumatological features like frozen shoulder, arthritis, swan neck deformity, and sensory problems like hyposmia and pain. Hyposmia refers to the decreased smell sensation. So yeah, these were the clinical features of Parkinson's disease. Now there is something called red flag signs of Parkinsonism, or this refers to the signs suggesting atypical Parkinsonism, signs that are not typical of Parkinson's disease, but it suggests atypical Parkinsonism. So what are these red flag signs? If the patient presents with fall early on, then it may be due to progressive supranuclear palsy or dementia with Lewy bodies. If the patient presents with dementia early on, then it may be due to dementia with Lewy bodies, progressive supranuclear palsy, or corticobasilar degeneration. Likewise, if the patient presents with the rapid progression of the disease, then it may be due to dementia with Lewy bodies or Creutzfeldt-Jakob disease, which is a prion disease. If the patient presents with prominent autonomic features rather than the motor features, then it may be due to multiple system atrophy. If there is stridor, then it may also be due to multiple system atrophy. So yeah, these are some red flag signs of Parkinsonism. And if the patient has a younger onset, as we discussed that the age of onset is usually 60 years, but if a patient presents earlier with the features of Parkinsonism, then it may be due to genetic causes like Huntington's disease, Wilson's disease, etc. Now let's talk about the investigations for Parkinson's disease. So firstly, structural imaging. So structural imaging like CT MRI, it is usually normal in Parkinson's disease, and it is done to rule out other etiologies like vascular etiology. There's something called functional dopaminergic imaging like SPECT scan or PET scan. So it is abnormal, but it is not specific for Parkinson's disease. It shows reduced dopamine activity in the basal ganglia. There's another imaging modality called dopamine transporter imaging, and this shows the extent of the disease. And genetic testing can be done if the patient has a family history of Parkinson's disease or some genetic causes to rule out the genetic causes. Yes, so these were the investigation modalities. Now let's talk about the management principles of Parkinson's disease. So first, let's go through this chart. It is the treatment algorithm for Parkinson's disease. I made this from Harrison. So it includes non-pharmacological as well as the pharmacological approaches. In non-pharmacological therapy, it includes exercise, education, support to the patient, physiotherapy, occupational therapy, and speech therapy, and many more. Now, pharmacological therapy, it includes neuroprotection with rasagilin, which is a MAO-B inhibitor. And if the patient already has functional disability, then we need to go for drug therapies like dopamine agonists or levodopa. And if the single therapy doesn't work, then we need to go for combination therapy. Any of these combination can work. And if there is no improvement with this pharmacological therapy, even with the combination therapy, or if the patient presents with debilitating side effects due to these drugs, then we need to go for surgery or continuous dopaminergic stimulation, including deep brain stimulation. And surgical management includes ablation like pallidotomy, thalamotomy, etc. Now let's talk about the pharmacological therapy. Pharmacological therapy, let's talk about some drugs used in Parkinson's disease. First one and the most important effective drug is the levodopa. It is given in combination with carbidopa in order to prevent its peripheral metabolism and its peripheral side effect, as carbidopa is a peripheral decarboxylase inhibitor. So it's the mechanism of levodopa is it is a metabolic precursor of dopamine. So it stimulates the dopamine receptors, and it is metabolized by MAO and COMT, MAO and COMT, and its side effects includes postural hypotension, nausea, vomiting, dyskinesia, confusion, hallucination. So this dyskinesia can be debilitating enough for the patient to stop the therapy. It also causes wearing off effect on long-term use, that is, its effectiveness decreases on long-term use. And the other group of drug includes the dopamine agonists like bromocriptine, cabergoline, sorry if I mispronounce, pramipexole, ropinirole, etc. So it is longer acting than levodopa, and it causes more uniform stimulation of the dopamine receptors, and it is less prone to induce this dyskinesia, which was very debilitating for the patient. So its side effects include nausea, vomiting, postural hypotension, and now it is noted that the patients with patients on dopamine agonists, they have impulse control disorders like pathologic gambling, hypersexuality, binge eating, etc. Other drug group includes the MAO-B inhibitors like selegiline, rasagilin. The mechanism of this group of drug is it blocks the central dopamine metabolism, and it increases the synaptic concentration of dopamine. So basically it increases the concentration of dopamine by inhibiting the central dopamine metabolism. Another group include the COMT inhibitors, including entacapone and tolcapone. So it prolongs the duration of levodopa by decreasing its peripheral metabolism. So it is used in combination with levodopa. Other group includes the anticholinergic, which includes benztropine and trihexyphenidyl. So it blocks the acetylcholine receptor at the basal ganglia. As we talked in the pathophysiology, acetylcholine, it inhibits the movement in the basal ganglia. So it blocks the acetylcholine receptors at the basal ganglia. Another drug is amantadine. So its mechanism is actually not known properly. Now this was the pharmacological therapy. Now let's talk about surgical therapy in brief. So mainstay of surgical therapy right now is deep brain stimulation of the subthalamic nucleus or the globus pallidus of the basal ganglia. So this is beneficial especially for patients who suffer from disability due to levodopa use. So as we talked, that levodopa causes dyskinesia, which is quite debilitating. So this is useful for that group of patient. The other surgical therapy includes ablation, including pallidotomy and thalamotomy. So yeah, this was about Parkinson's disease, its management, its investigation, its pathophysiology, its clinical features. So I hope you gained something from this video, and see you in the next one. Thank you.